So I'm quite pleased to introduce Dr. Thuy as today's CFAR speaker. Dr. Lay is Associate Professor of Medicine and Associate Professor of Genetics and Microbiology at Duke. She is trained in internal medicine and infectious diseases. She received her PhD in Epi from Oxford University. She spent 10 years in Vietnam studying tail rope mycosis, which is an important opportunistic in HIV-infected persons. The scope of her work is fantastic, and it spans from ecological studies to developmental diagnostics to multi-center clinical trials published in the New England Journal of Medicine. So it is just an amazing spectrum of work. She was a CFAR recruit to Duke in 2019 and recently was appointed as the CFAR Clinical Core Associate Director. So welcome, Thuy. We're so thankful to have you here with us.
Thank you so much, John. That is such a kind introduction. I want to thank everyone for being here and for your attention. I know it's a very busy time, and the fact that you are tuning here, listening to our work in Southeast Asia, I really appreciate it. I'm also very excited to be part of CFAR community. I've been doing HIV for more than a decade now in Southeast Asia, and been sort of a bit removed from the mainstream Western medicine. And so it's really a privilege to be back, and being part of CFAR is really the best way to get my feet back into the ground here. And so I really appreciate everybody's support and such a wonderful opportunity to play an important role in the clinical core of CFAR. So I really am excited to the few years ahead, and thank you very much for your support. So I think my title is a little bit ambitious, you have to say, and I'm going to try to do my best to let you see the work that we do and the vision moving forward. So it's not practical to kill 3 birds with 1 stone, but I hope that I'm putting it out there to kind of sketch your mind and allow you to see the vision that we are moving forward. So the global HIV pandemic doesn't really need any introduction here. The HIV pandemic was recognized here in North America and Western Europe in 1980s, early 1980, and the yellow bars show the burden of disease in these continents. And it spread rapidly across the world, but the true burden of the disease is in the developing world, with 70% of disease in Africa, sub-Saharan Africa, 20 to 24% in Southeast Asia and Latin America. So this graph doesn't mean to say that the work, HIV work to be done in this country or Western Europe is not important. In fact, it's the other way around. We actually need lots of research pouring back in this country in terms of getting HIV care and treatment continent up to date. And work on HIV vaccine will be really a game changer for this disease. But I really wanted to show this to really show you the disproportionate proportions of a burden of disease in developing world and really shine the light in Southeast Asia. I think this region of the world is rapidly growing in many ways, populations, economics, and with that comes all sorts of different problems, climate change, as well as the social change and all of these things. And I think that Southeast Asia historically get a lot less attention from the research as well as policy community. So we have really witnessed tremendous progress in HIV therapy, right? Antiretroviral therapy really changed the game in terms of averting death from HIV, right? 12 to actually millions of deaths being averted by antiretroviral therapy. And it's really a remarkable success. But really the most recent remarkable success is that HTPN052 study that was run by Michael and here, our neighbor at UNC, and that showed a 96% reduction in terms of transmission in the serodiscordant couple. And that is the highest prevention efficacy compared to any other pharmacological or male circumcisions or any other PEP or PrEP type thing. But really, PrEP type thing is really fantastic. And that really changed the game in terms of prevention here. And that study published in the New England Journal of Medicine in 2016 really kickstarted a lot of excitement in terms of how to deal with HIV and how to end AIDS. And the WHO followed that a few months later with a recommendation in June of 2016 to treat everybody with HIV regardless of Cd4 count, right? Up to this point, the WHO said treat with a Cd4 count less than 500. It was less than 350. Before that, it was less than 200. And now WHO said treat everybody. Why? Because it's not just improving the outcome of the single individual patient, but we're talking about disease prevention. And that really kickstarted this whole idea of test, prevent, and treat. So you got to test everybody. If they're negative, you give PrEP to people with high risk, and you give therapy for everybody who tests positive, regardless of Cd4 count. And that has an issue in itself in terms of not dealing with Cd4, which I come to in a little bit. And then the UNH begin to set targets, right? Now that you've got effective way to prevent transmissions, and the UNH actually set up this major target in 2016. Again, actually the documentation came out January 1st, 2017, of the 90-90-90 target. And what that is that 90% of people with HIV should know their status by 2020. And of those, 90% should be on ART. And of those who are on ART, 90% should be virologically suppressed. So that translates into 30 million of people out of 38 million of HIV infected people should be on treatment, and translate into 90% of people know their HIV status, 81% should be on therapy, and 72% should be virologically suppressed by 2020. And another target that they set up is fewer than 500, 500,000 new infection a year. So how are we doing in terms of meeting that UNH target in 2020? This is a publication last year, UNH target here. This is new HIV infection globally, and we are at 1.7 million new infection a year, which is far from this target right here of 500,000 new infections. So we are off by a far margin here, more than 3 times off the target for new infection, despite the availability of ART, despite these PrEP and PrEP prevention strategy that everybody was so excited about. And how are we doing in terms of HIV-associated death? This is a slide I borrowed from Tom Chiller at the US CDC when he gave a talk at the HIV-associated mycosis meeting in South Africa in 2019. And so this is the target for UNH. At the same time, the target should be reducing death from 1.5 million, in 2010 to 500,000 in 2020. So that's a 75% reduction over 10 years. That's very ambitious. And where we are about here. So we are about 700,000 deaths a year with a high estimate of about 1 million. So we are about 1 million, and again, far from the target of 500,000 deaths. And even if we meet the 90-90-90 target, we still only bring this down this much, according to his model projection here. And so there's a lot of death that need to be avoided. And a lot of HIV death, as you know, the causes of death that people no longer talk about. If you go to CROI, I'm sorry, I don't know why my slide's jumping ahead. But if you go to CROI now, over the last 5 years that I've been, people don't talk about opportunistic infections and pay much attention to these opportunistic infections. These are really how you're gonna really save life. You have to save life before you can get the patient back on their feet and have the opportunity to be on ART and benefit from prolonged life that everybody get. Right now, HIV patient should have normal lifespan. And so, but if you don't treat these fungal infection and tuberculosis, you're not going to give that person an opportunity to have the normal life. And you know, I think that a lot of research focus have really no longer thinking about how you're going to save people life from these opportunistic infection. So challenges in HIV-associated related mycosis, including cryptococcal mycosis, histoplasmosis, Tylomycosis, PCP, these are the big player, are that these are leading cause of HIV-associated death after tuberculosis. The number of patients entering care with Cd4 count less than 200 have not changed over the last decade. Despite ART, the number of people who enter in care with advanced HIV disease have not changed. With increasing numbers of ART treatment, there's more patients who are failing therapy or who are stopping therapy. So these are the kind of group that people no longer talked about. These are the people that, you know, never going to go away. There's people going to fail therapy. There are people who default on treatment and people who don't know they're infected. In terms of diagnostic for fungal infection, as you know, most fungal infection rely on decades-old, very protracted culture methods, and that fungal infection rely on these culture methods. You know, really missed a lot of infection. And there's suboptimal therapy. There's really limited options in terms of antifungal therapy, limited availability in developing world where these fungal infections are prevalent, and the toxicity of some of these drugs, you know, amphotericin B, deoxycholate, quite toxic drugs. The mortality, even on treatment, is 20 to 60%. And so, you know, we are not going to get ahead without any sort of drastic change in terms of the way we approach these fungal infection. One way that we can approach reducing disease burden is by giving primary prophylaxis, primary antifungal prophylaxis to everybody with low Cd4 count. And this strategy has been advocated in the past, and it has shown in randomized control trial, both for crypto and Tylomycosis, to reduce incidence of invasive mycosis, but not quite reducing mortality because the sample size are not large enough. However, the approach to give a blanket treatment to everybody with a Cd4 count less than 200 with these antifungal drugs that are you know, have significant side effect. There's significant antifungal drug interaction with ARV. There's drug resistant issue if you're gonna give these drugs long-term, because none of these gonna be short-term prophylaxis, right? You give these for a year. And there's issue of cost. Who's paying for these? They're not cheap. And so this approach is not practical and therefore no longer advocated by any sort of government or policy. So there must be a better way to approach this. And cryptococcal meningitis is really a disease that provides a model for fungal preventions. And as you know, cryptococcal meningitis is a huge cause of mortality, right? 180,000 cases per year, 135,000 deaths a year and made up 15% of HIV-related death globally. And the fungus is in the environment, and it gets into the lung, and it doesn't go away. Patient become latently infected, and when the immune system is suppressed, they develop disseminated disease, and it gets to the brain and really cause problem. Mortality is up to 60% despite antifungal therapy. So Joe Jarvis, more than 10 years ago in 2009, did this really fabulous study where he tested cryptococcal antigen in patient blood in a cohort, retrospective cohort in patient blood that they had follow-up blood work. And they basically found that cryptococcal antigen is positive in the blood of patients in median of 22 days, up to 234 days, so about 8 months before cryptococcal meningitis developed. And this is really revolutionary. It basically say that you can actually detect an antigen, a protein in a patient's blood 8 months before disease developed. And this really provides a very nice window of opportunity for pharmacologic intervention, pharmacologic prevention. And the development of a point-of-care diagnostic called CRAC test. So it's basically like a pregnancy strip test that you can do at the point of care. You can screen these people, and if they're antigen positive, you could treat and prevent disease development. And this has been shown in cohort in Africa. This cohort in Uganda by David Meyer. And you could see in this graph, there's a significant mortality benefit with people with CRAC positive. It's a small study, but it shows you here that if you treat CRAC positive people with fluconazole, the mortality is significantly different than not treating at all. So nearly 100% mortality here without treatment, and with treatment mortality is, here in this small cohort, 15%. Another cohort that they did here in Uganda, as you can see, there's a significant difference in mortality between those with symptomatic cryptococcal meningitis, right? Mortality is down, is 60%, versus asymptomatic CRAC positive people without symptom of meningitis. And mortality is significant, is 20%. So there's a significant difference here. You can catch these people early and prevent disease, prevent death. How much does it cost to do this CRAC test? It's $5 a piece. Whereas hospitalization costs to treat cryptococcal meningitis is about $200 in Uganda, $600 in Vietnam, $3,000 in South Africa, and $70,000 in the USA, right? So the cost of this group of investigators at the University of Minnesota have did this cost effectiveness analysis here. And as you know, the prevalence of CRAC in the world, in the lower middle income countries, is about 6%. And what they did was they found that at the threshold of 1.5% prevalent, then you would be cost saving in terms of screening for CRAC. So you screen for CRAC, even at a prevalent of 1.5, you save costs. So it's not just saving life, but saving costs. And these studies, even though they're not prospective randomized study, have really propelled the WHO to come up very quickly in 2011, based on just retrospective study, with this rapid advice of 3-step to prevent cryptococcal meningitis, to screen, to detect, and treat people with a Cd4 count less than 100 using the CRAC test. So that's really a fantastic example of how policy get on, and these researchers are able to act very quickly and get WHO to get on board. And now CRAC screening is in national guideline in 22 different countries. Still not enough, but it's a step forward. And the WHO guideline really kickstarted 2 very important trials that really consolidate this sort of evidence-based medicine. And the first one is the RAMSTAR trial. I really apologize. I don't know why my slide keep jumping ahead of me. I'm not doing anything. But anyway, the REMSTAR trial is a randomized trial published in the Lancet 2015, where researchers in 4 different countries in sub-Saharan Africa randomized about 2,000 patients to screening for crack and community support versus the standard of care, which is basically reactive, treating with positive Cryptococcal meningitis. And they show a significant mortality benefit, right? So 28% relative reduction in mortality. The second trial was published in New England Journal of Medicine called Reality Trial. And this study was done in, I believe, 16 different centers in the community of sub-Saharan Africa. And what they did was they gave a package of primary prophylaxis, which include fluconazole for cryptococcal meningitis, INH for TB, cotrimoxazole for PCP and malaria, and 5 days of azithromycin as a package of primary prophylaxis in the community, remote community of sub-Saharan Africa. And they recruited, again, about 2,000 patients. And what they found here is there's the 24% reduction in mortality with this sort of package of care. And actually, I was sitting in the WHO guideline committee reviewing these guidelines, and we were not very excited about azithromycin. Obviously, INH and cotrimoxazole has already been recommended. Fluconazole is an issue that we just talked about. When we look at the specific cause of death and reduction of death, really the 2 area that driving this mortality benefits are cryptococcal meningitis and unknown category. And I would argue that this unknown category is probably undiagnosed tuberculosis and other fungal infection. But cryptococcal and TB, again, are the drivers of this. And so we decided the guideline not recommending azithromycins and fluconazole, but we actually decided in 2018 that to provide this sort of package of care for advanced HIV disease that focus very much on screening and preventing disease for cryptococcal meningitis and TB. So again, that same recommendation that we had before is to do crack screening and INH for everybody with HIV, and also cotrimoxazole, and only give fluconazole for crack positive people, along with rapid ART initiation of course and adherence support. Now, this is really an important step forward, this sort of package of care recommendation for HIV, for advanced HIV disease, which I think is crucial. But the problem here is that nobody look at outside of Africa. This guidelines are very much focused on Africa, right? And nobody really look at outside of Africa. For example, in Southeast Asia, we got Tylomycosis. In South America, Latin America, we got histoplasmosis. None of those were put into the guideline. And I'm a very verbal person, and I spoke up, but we didn't have enough data to support. So that fall back to us as researchers to really generate the data needed to support this sort of policy intervention. So that's really is the mission of our work. Now go back to Southeast Asia. So Asia Pacific made up 60% of the world populations. And we talked about it having, 25%. So the burden of HIV disease is highest outside of sub-Saharan Africa, and very little attention being paid to this region of the world. So how are we doing in terms of meeting the global 90-90-90 target? This is global statistics. It should be 90, 81, 72, but we are in reality in that publication that I showed you earlier, we are 81% of people who know their HIV status, only 67 on therapy, and only 60% of HIV infected patients globally are biologically suppressed. So we are far from this 90-90-90 target. And the UNAIDS already marching forward to zero HIV, zero AIDS by 2030. And I will reckon to say that that's a lot of work need to be put into the ground in terms of implementation of what we already know work. And there's a huge gap here, as you can see. So how is Asia Pacific, how is the region doing in terms of meeting these? As you could see here, this is 2020 statistics here, 75% compared to global of 81%, 60% of people who are on therapy compared to 67, 55%, 55% are virologically suppressed. So Asia Pacific, which includes some, developed country, Australia's and Singapore, Hong Kong, and etc. There's some high resource country here too. And altogether, we are doing worse than the median of the world in terms of the statistics. And we're doing much worse compared to Sub-Saharan Africa here in terms of meeting the 90-90 goals. So a lot of attention, a lot of work needs to be done in this region of the world. How are we doing in terms of Cd4 count? This is the prevalence of Cd4 count among newly diagnosed HIV in Asia in 2017 and 2019. So on this 3-year window. As you can see, yellow, the light yellow indicates Cd4 less than 200. And these are the numbers in the country. I mean, this is really terrible compared to even Africa. The number of Africa is about 30% with Cd4 less than 200. We have about 40 to 50% across the board here. And if you look at the places with either 50% or more age prevalent, it includes Indonesia, Philippines, Papua New Guinea, Thailand, and Vietnam. And there are some countries in red here or orange here. So the country in orange show you that the prevalence of advanced HIV disease actually going the wrong direction. So it's actually worse, rising AIDS incident in Afghanistan, China, Indonesia, Laos, Malaysia, Philippines, Sri Lanka, and Thailand. So we have rising AIDS incident in this region of the world. This is totally unacceptable. So this brings you to my work. Sorry, that's a long sort of introduction to my work and vision of our work. I was based at the Oxford University Clinical Research Unit in Vietnam for 10 years before I returned to the US and joined Duke. So in this hospital of 600 beds, we really care for all infectious disease, tropical infectious disease in the entire southern Vietnam with a catchment population of 40 million people. So we do see all sorts of different tropical infectious disease that you can imagine. Malaria, dengue, enteric fever, emerging infection. We actually saw SARS and all of that emerging infectious disease, tuberculosis, CNS infection, HIV, zoonosis. And the Wellcome Trust has the unit that is located within the hospital for 35 years. And this is the Wellcome Trust Oxford unit. We are located in the first floor of the hospital laboratory building here. So we're very intimately involved with the hospital and a few steps away from the patient ward. So it's very fantastic sort of research environment, and it's a fantastic way to train for infectious disease. At our hospital, we see this is the number of deaths at our hospital from 1994 to 2010. And I just wanted to show you here is that death incident decreasing due to malaria, dengue, and so forth, but then it rises in the mid-2000s, and that was due predominantly to HIV in blue color here. And when we look at the causes of death in our hospital, 35% are due to tuberculosis, either confirmed or clinical diagnosed tuberculosis. And then 23% are due to culture confirmed invasive mycosis, and of those, cryptococcosis 10%, Tylomycosis 8%, and PCP 5%. So as you could see here, TB and fungal disease made up 60% of cause of death in HIV patients. So it's a significant issue that need to be discussed. So what is Tylomycosis? It used to be called penicilliosis. It is one of the 7 endemic mycosis of medical importance in the world. It's endemic in Southeast Asia, and it caused a systemic infection that involved multiple organs. It's again go into the lung and get into the disseminate through the reticular, get to the lung and disseminate through the reticular endothelial system, go to liver, spleen, bone marrow, And eventually the patient can have sort of indolent course for a month of fever or not doing well, weight loss for a month before they show up with skin lesions and disseminated disease. And by then we get, we recognize and diagnose them by blood cultures. Blood culture takes 14 days to grow. So by the time these patients come in a previous trial that we conducted, 7% of patients die before culture become positive. So by the time we make diagnosis of these fungal infection, it's already end state and disseminated disease. So it's a horrible infection. As you can see, in terms of epidemiology, the epidemic curve are go hand in hand with the HIV epidemic curve in Thailand and Ho Chi Minh City here. This is our work in that hospital over 13 years window. But what I want to draw your attention to is the incidence of telomycosis just a few months ago that show a higher incidence of AIDS as well as telomycosis. As you could see, the red line is telomycosis case, and in 2017, there's 250 cases a year, and the numbers are rising, along with rising HIV/AIDS cases. And it's just not just because we have more HIV patient than telomycosis patient. The prevalence of telomycosis also increasing among patients with AIDS. So going from 11% here, walk up to 18.8% prevalence. And we have not changed in terms of diagnostic or recognition of disease. I mean, if anything, it's we know this is all by culture confirmed so far. We haven't done anything different in terms of improving diagnostic routinely in the standard of care. So this is worrisome. The prevalence also increasing, which tells me that there's possibility that the reservoirs in the environment is increasing due to global warming or whatnot, but the prevalence also increasing, not just the cases. And telomycosis is the leading cause of death in this study at Guangxi, which is a province next to Guangdong in China. Huge number, 300 million people. And basically what they found here in this study was published in 2019 of more than 6,000 hospitalized patients from 2012 to 2015. The cause of TM, telomycosis, is the leading cause of death of 50% compared to other cause of death, including TB, Cryptococcal Meningitis, and everything else. So TM is the leading cause of death in southern China, and the numbers are increasing along with HIV incidence, and nobody's talking about this. If you go to Google, you go to any guidelines, you go to even China guideline, they're not there, because people don't even talk about it. That just tells you the remarkable level of neglect of this disease have in the world. We realize that we can't really attract funding and research amount dollar or policy attention if we don't estimate the global burden of disease. So we started this work with collaborators in China, begin to systematically document all the cases that have been reported so far. And this paper, we're still working on this paper now, but we reported this data at CROI last year. There's so far 25,000 reported cases in 33 countries by 2018. And 99% of them are in the endemic regions of Southeast Asia, Southern China, northeastern part of India. But there are other cases around the world really due to travel-related cases. And Thailand, Vietnam, and China are the highest burden country with estimated 17,000 cases and nearly 5,000 deaths occur yearly. And these are only based on HIV population. Now there's a growing non-HIV population with this disease as well. So this disease is not unique to HIV. There's a growing population of non-HIV immunocompromised patients that are infected with this as well. And we estimated that because the AIDS incident in China is increasing in blue here, and we're going to have increasing cases of telomycosis, in the next 5 years, up to 35% increase. So what are we doing about diagnosis? Going back to very first slide, what is our approach in terms of reducing disease burden? We have to approach this with a very comprehensive strategy. There's no one way, no one simple strategy, right? So we have to improve diagnostic in the first place. We have to get better and do better in terms of diagnosing and use non-culture-based diagnostic. Right now, the gold standard is to diagnose based on histopathology and culture. And I mentioned to you that it takes a very long time, and culture positive only 50 to 70% of cases. Real-time PCR has a role, and the sensitivity is improving. We're working on novel PCR assay right now in our laboratory, and we get to about 90% sensitivity. And this is fantastic. PCR is very specific. You're looking at a genome specific for Tylomyces, and you should be very specific. And if you get to 90% sensitive, that's great. So we're working on this at the same time, but PCR is, requires sophisticated machine and skills, and not, not readily available in places like Myanmar, Vietnam's, and India's, and rural areas of China. Antigen detection, I think, is the way to go in terms of point of care diagnostic, and it's simple, accurate, promising. And I'm going to focus a lot of my time talking about that. So we're working on an antigen detection assay that was developed by my collaborators in Hong Kong. Professor Ki Yun, he is a surgeon microbiologist, University of Hong Kong, really fantastic guy who's really working on SARS-CoV-1 and now SARS-CoV-2, working on vaccine. But he basically, he systematically screened for immunogenic protein and identified a protein called MP1P, which is a cell wall protein of Telomyces that is released in abundance in the circulation, in the blood, and in the urine of the patient, that can be detected by serological diagnosis. He also developed monoclonal antibody, polyclonal antibody to detect this particular protein. He first of all, he cloned the protein and developed antibodies. So we have a ELISA assay to detect antigen, right? So it's a perfect target for antigen detection assay. We evaluated this assay in a cohort of 372 Tylomycosis culture-confirmed patient in control, and we found a sensitivity of 86% versus 72% of blood culture, with specificity of 98% and a diagnostic AUC of 96%. So in other words, it can differentiate between disease and no disease 96% of the time. So that's fantastic. And this is a retrospective store sample that we didn't dig out in the freezer to do this. So the next step for us, we published this last year, the next step for us is to take this assay prospectively to really study the clinical relevance and utility of this assay in clinical practice. The other thing is to understand what it means to have asymptomatic antigenemia. So we need to learn from Cryptococcal Meningitis field that maybe we can screen for antigen in asymptomatic HIV patients starting ART and see if we can document that people who are antigen positive will develop Tylomycosis if we don't treat them. And so we are currently doing this prospective study, but I just want to give you this sort of preliminary data that we have in southern China. The prevalence of asymptomatic antigenemia in these two provinces in China is 9.4%. And in Vietnam, in a large study of 23 clinics across Vietnam here, in people with Cd4 count less than 100 in clinics starting ART, the prevalence of asymptomatic antigenemia is 4.2%. So next step is to understand what it means to have asymptomatic antigenemia in these people, and again, develop evidence for change in clinical practice. What we found in this Vietnam study, when we looked at 12-month mortality, antigen positive is an independent predictor of death, independent from crack positivity and Cd4 count and age. So as you could see in the Kaplan-Meier curve here on the right, mortality in antigen positive people is 30% compared to 9% of antigen negative people. And this is independent of crack positivity. Now, what interesting thing interesting about this study is that the population who are CRAG positive and TM antigen positive are different. Of all these people that we screen, the people who are antigen positive with CRAGs are not the same as the group with TM. So they're two distinct populations within the same population. There's only one patient with two antigen positive out of this whole 1,000-patient study. So I think this really created really interesting opportunity for us to really screen for multiple fungal infection in one population. And this is what I mean by killing two or three birds with one stone. In the same population, you can screen for multiple fungal infection using these point-of-care diagnostic. This is just to let you know that this test that we're using, which is a homebrew assay, has been developed into a commercial platform in China that has been approved for clinical use. And my colleagues, Dr. Linghua Li in Guangzhou, have recently done the study. She reported at CROI in 2019 that the prevalence of antigenemia in her clinic of 236 patients enrolling in care was 20% compared to Cryptococcal meningitis antigen of 3.4%, which is more in line with the prevalent in other countries in Southeast Asia. So clearly, this is just to show you the burden of telomycosis compared to cryptococcal meningitis in our region of the world. So we are currently working on a prospective study to understand this diagnostic. So we're recruiting two cohorts, one symptomatic hospitalized cohort, and the other is asymptomatic cohort. Screen them as they enter the door with any symptoms at all with antigenemia alongside conventional diagnostic with culture, fungal culture, and everything to really understand the diagnostic utility of these assays. And our preliminary study that we presented at CROI in 2020 show of 533 patients that we screened, the sensitivity of this assay is 97.5%. So that was much higher than the retrospective study that we did using store sample. This is prospective sample, 97% sensitive in detecting telomycosis after 6 months of following these patients, detecting culture positive disease. Whereas culture in all form, culture of lymph node, culture of blood, cultures of bone marrow, only detect disease 85% at baseline. And so as you see, 12 patients who are antigen positive develop disease within 6 months of follow-up that were culture negative at baseline. So clearly the sensitivity outperformed culture. And now this is proven in a prospective study. Specificity is 96.7% in patients with advanced HIV disease. Now, these 16 false positive cases, you could almost argue, well, 6 months we follow these people and they didn't develop telomycosis, but you could argue that they probably have antigenemia, and by starting ART, it's probably attenuate the development of the disease. And we need to dig deeper in science to really prove that, but we really think that these are not false positive because the nature of the genes, MP1 and MP1P protein, is very, very unique to Telomyces and doesn't cross-react with any other fungal. This is just to show you that urine is a fantastic specimen for diagnosis. What we found here is that urine is even more sensitive than plasma and sera in detecting antigenemia, with urine is 95% and 98%, 99% specific. If we combine either plasma or sera with urine, then we achieve the 97% sensitivity that I just reported earlier. So urine alone, if you don't do this in sera plasma, if you just do this test, you're getting non-invasive sample from patient in the community. You can diagnose a disease from urine, which is fantastic. And this is what we do for histoplasma as well. And so that's really a very, very consistent data. And this is just to show you time to culture positive disease in the 12 patients who were antigen positive but culture negative at enrollment. As you could see, that one patient developed disease 16 weeks after the antigen positive. We follow them, develop culture positive disease. So the test can detect disease up to 4 months before culture disease develop. So that really allow us, again, now we have the evidence, we are building evidence to show that we can probably screen asymptomatic patient at the time of disease dissemination, before clinical manifestation develop. And if we can do that and provide itraconazole prophylaxis therapy, then we can prevent disease development and avert disease development and mortality. We can do this for histoplasmosis as well. Now, remarkably, histoplasmosis has been around for so long, and an antigen test has been around for so long, but no study have been done to really document this sort of natural progression of histoplasmosis. So this needs to be done as well, and it's my hope to do the same thing in Southeast Asia now. So we're now screening for cryptococcal meningitis, Tylomycosis, and histoplasmosis in Vietnam in the same population. And I am glad to report that we just started enrollment of this NIH-funded prospective multi-center study. And we enroll about 30 patients so far. And of 30 patients, we have 3 cases of histopositive antigen. And we've never diagnosed histo. It's not easy to diagnose histo because it takes 4 to 6 weeks to culture, and we don't do that kind of cultures. And that's why we've been missing histo in Southeast Asia. So I'm very excited to see what's going on. And the whole idea is that the same 3 diagnostics that are readily available can be used to screen the same population, and that we can hopefully prevent histo and Tylomycosis the same way we have for cryptococcal meningitis. Now, moving forward, we need to take these assays to commercialization, right? You can't do very much if you don't work toward commercializing these assays and bring it to the bedside. So we receive an NIH SBIR working with IMI to develop a lateral flow antigen detection assay for Tylomyces. And we in phase 1 grant now, and we have fantastic results so far. So the LFA perform very, very close to the EIA and missing really just a couple of cases here and there. So that's really, really good news. And moving forward, we are going to go for a phase 2 grant, which will allow us to develop a multiplex assay. So the vision is to put both cryptococcal antigen and Tylomycosis antigen detection on one strip. It's going to be a little bit, technically it will be difficult. We like to do that because the company already have the crack test. And if we can add the TM antigen test on this and kill 2 birds with 1 stone, that would be fantastic. Obviously, they also have histoplasma antigen right now in the EIA form. So eventually they should be able to put this on one strip test that tests for 3 fungal infections in one stone. And that's what I mean. Another way to do this is to put on these sort of different platform. And I'm collaborating with Tosh Chakoti, head of bioengineer here at Duke, to develop a D4 point of care platform. So what he has is a polymer material put on a glass slide that doesn't bind any other protein. So you have to impregnate the antibody on, and then you detect what you want to detect. So essentially, it's a multiplex ELISA on a chip that doesn't have any non-specific binding. So get rid of all the non-specific binding of an ELISA plate platform. So that's really fantastic. And you can put 20 different tests onto this platform, onto the single slide. So I'm very excited about moving forward, working with him on this. We received some seed funding from the Duke Global Health Institute to develop this point of care last year, but he's been busy working with COVID, and we'll have a little bit of a slow start there, but we are hoping to eventually move on to, if we are not successful with LFA, we're going to try to shoot with this diagnostic platform for multiplex assay. So that brings me to the conclusion. And so antigen detection is superior to culture in sensitivity, in time to diagnosis. It can detect disease 4 to 8 months prior to culture positive disease, and independently predict mortality in patients with advanced HIV disease. And so these are really a nice way to pave ahead of us. We just need to now collect data to really prove this. I think really, to put it out there to junior investigator who wanted to work on this field, I can tell you that the field is made up for you. It just needs your work to jump in willing to go to Southeast Asia to work. So I want to inspire young infectious disease or medicine fellow or resident out there to work on this disease, because I think there's a lot to be done in terms of making a difference. So rather than reactively treating late-stage infection, which we are doing now, or giving primary antifungal prophylaxis, which is not a practical strategy, our strategy would be a diagnostic-driven approach: screen, treat, and prevent disease. And we can do this with, there's a vision to do this, and we can do this very cheaply, effectively. So thank you so much for your attention. And I'm sorry I'm sort of running out of my own time. I wanted to give more time for discussion, but looking forward to your input, and I hope that my work will stimulate a lot of collaboration, or if other CFAR investigators want to expand your HIV work in other field in Southeast Asia, please get in touch. I would be very delighted to collaborate.
So thank you, Thuy, for a fantastic talk. Perhaps I can ask the first question. And as a clinician, I'm wondering how often you see immune reconstitution disease with Tylomycosis if you start patients on ART.
Yeah, great questions. We do see immune reconstitution disease, John, and actually quite a bit number. In our prospective randomized trial, 440 patients, we follow for 6 months. The iris incidence is about 5%. So we do see very clear inflammatory reconstitutional syndrome, and these patients presented with more worsening skin lesion after it's already completely resolved. They're looking more inflammatory rather than sort of necrotic. And they can go back in with like lymph node swelling and joint swelling, actually very interesting joint swelling, small joint particularly. And what we do is we just treat them, continue the antifungal therapy, continue ART. Some people decided to induction in terms of giving them amphotericin B if they was treated with itraconazole, and they think that there may be some issues of persistent fungal in the system. And when you start patient on ART, there's this very dynamic issues of having persistent antigen in the patient blood because you not adequately treat the patient with itraconazole. And then when you start ART with the immune reconstitution, there's an issues of immune inflammatory response. And I think we're trying to prove that. That's one of my research area that I want to tap into, and collected PBMCs and everything to try to do. And actually that's one of the CFAR seed funding for me to do, and I haven't gotten that off the ground. But that's one of the issue we want to address, John, is that we have this cohort of people who develop immune reconstitution disease, and all of them are in the itraconazole arm. And what we want to show is this sort of interaction between host pathogen that causing this phenomenon, and that argue for very effective antifungal therapy, induction therapy at the start, so that you can get rid of fungus very quick, very fast, and allow people to get started on ART safely. In the amphotericin B arm, no one developed iris. They develop relapse if they stop antiretroviral therapy, but no one developed iris. So that tells me that effective, rapid antifungal therapy, such as amphotericin B, is the way to go. And that's the recommendation and the standard of care right now.
Sure. So there are questions or comments?
Thuy, I have a question. A very nice presentation. Very, very nice. The question is, with this antigen, we know that with CRAGs, the actual treatment or the preemptive treatment is failing significantly. And in fact, they've had to change the regimens potentially, or study regimens that are not azole based, or at least not only azole based, to try to see if they can get by the failures. What do you think about Tylomycosis as far as itraconazole? Do you think it will perform better than CRAG? And also, we know that CRAG never works very well as a marker for continued disease and stuff like that, so we don't really follow it. But in your antigen and stuff like that, is it pretty much associated with reduction of organisms and organisms eliminating from the host?
Thank you, John, for those two questions. Your first question's about, yes, so we know that fluconazole is a suboptimal therapy for CRAG-positive asymptomatic people, right? Mortality is still about 30%, which is much higher than CRAG-negative patients. Mortality is about 10%. So clearly show that fluconazole azole therapy is not optimal to treat even asymptomatic CRAG-positive people. And that's really why, as you know, Tom Harrison, I think you and I on the student committee in that trial that he just received funding for finally from the Global Health Trial to do a randomized control trial comparing fluconazole plus flucytosine combination therapy for CRAG-positive people. I'm very excited about that. I think that is, I'm going to beg my money on it if I am. You have $1,000. I'm going to back all $1,000 on that study that it's going to show mortality benefit, because we've already shown in ACTA trial that fluconazole and flucytosine is as good as amphotericin B flucytosine in terms of reduction. So to answer your questions about Tylomycosis, we don't know, because we haven't screened for these people and we don't know how to treat these people. But my suspicion, based on your question, based on what we know, John, from crypto, and based on what we know from Tylomycosis that I've shown you so far, is that it's not going to be effective. So I don't think itraconazole going to be as effective for asymptomatic Tylomycosis anagenemia either. And so that's really another study to be done. Again, another study to be done, particularly because 5FC is going to be, it's generic, being generically produced by multiple companies now. And in the next couple of years, it's going to be much cheaper, right? Right now, 5FC is astronomically expensive because it's being produced by one single company and monopoly. But in the next 2 years, 5FC is going to be cheap. And that's going to be a tremendous tool for CRAG-positive, asymptomatic, TM-positive, asymptomatic, histoplasm, most asymptomatic. So I think that's going to be an exciting study to be done. Your second question regarding the using antigen for follow-up of patient care, we've done this, John. So we did with the IVAP trial. We follow anagenemia over the entire 6 months, and we found that anagenemia resolved after 4 months. So very similar to histo. Not like crypto. I know for crypto you can have anagenemia forever, for a year after being successfully treated. But for histo, it's about 4 months. And we see the same thing in in Tylomycosis. So we are conducting that study right now as we speak, doing analysis to look at the correlation between anagenemia dynamics, clearance, and correlation with mortality, correlation with disease relapse and complication based on our trial 440 patients. So we have a very nice cohort to answer your questions, and we're looking forward to do that within the next few months or so.
Well, thank you, Thuy. It's such an impressive body of work. It's just fantastic. So we appreciate your sharing it with us, and we can't wait to help you continue this work. So thanks everybody for participating today, and a special thanks to Dr. Thuy Le for her presentation.
Thank you so much, John, and thanks everybody for your attention. Have a wonderful, wonderful day.
Bye.
Bye-bye.